Welcome and thank you for joining us for the webinar, Go with the Flow, Cystatin Use in Solid Organ Transplant, presented by the AST Transplant Pharmacy Community of Practice and the American College of Clinical Pharmacy, in partnership with the AST Kidney Pancreas, Liver and Intestinal, and Thoracic and Critical Care Communities of Practice. Before we begin the main presentation, we have a few housekeeping notes to help you engage with today's discussion. In a few moments, you will see a poll appear on your screen. We ask that you please take this so we can get a better idea of how many people are viewing with us today. This journal club is being recorded and the archive will be available next week on the COP hubs. Please note that all of your lines have been muted so that only the presenters and panelists can be heard for the archive recording. If you have a question for our panelists during the webinar, we encourage you to participate by using the Q&A window in the Zoom webinar panel to submit your questions for consideration. Questions submitted via the chat section may be missed during the presentation. Finally, at the conclusion of today's webinar, a short survey will appear on your screen. Please fill out the survey to help us keep our content current and engaging. I will now turn the session over to our moderators to begin the presentation. Thank you.
Good afternoon and welcome to today's session. My name is Jamie Schulte. I'm an abdominal transplant pharmacist from Thomas Jefferson University Hospital, and it is my pleasure to moderate our session today alongside Kelsey Zukowskis, a solid organ transplant pharmacist from the University of Utah Health. Today's webinar will be focused on Cystatin C use in solid organ transplant recipients, and we are very fortunate to have 4 speakers of various backgrounds here today to review the literature and share their clinical experiences. We'll be covering a lot of really great information today with some main themes as below. Strengths and limitations of Cystatin C use in various patient populations within transplant will be discussed. We'll hear about literature evaluating the relationship of use to clinical outcomes. And lastly, a conversation about medication dosing principles with the use of Cystatin C and apply those to specific patient case examples.
We have a wonderful group of speakers here today, all with extensive and unique experiences with Cystatin C use in our transplant population. Our first speaker is going to be Dr. Vasanthi Balaraman, a transplant nephrologist and medical director of the Living Donor Kidney Transplant Program at University of Tennessee Health Science Center. Our second speaker, Dr. Sumeet Asrani, is the Chief of Hepatology and Liver Transplant at Baylor Dallas Fort Worth, Texas, will be joining us to speak to utilization in the liver transplant population. From Mayo Clinic Rochester, we have Dr. Erin Barreto, an Associate Professor of Medicine and Pharmacy and a critical care pharmacist who will be partnering with her colleague, Dr. Adley Lemke, an abdominal and cardiothoracic transplant clinical pharmacy specialist. I'll turn it over to Dr. Balaraman to get us started.
Thank you for the introduction, Kelsey and Jamie. I'm excited to be here. I'm going to be talking about background of Cystatin C and the literature review in the kidney population. I have no relevant financial relationships to disclose. So before I start talking about Cystatin C, which is a specific renal function marker, I want to spend a little bit of time in talking about the various different renal function markers that are available. The characteristics of an ideal marker for GFR should be one that's endogenously produced in the plasma at a constant rate. It's something that should be freely filtered at the glomerulus, and it should neither have any reabsorption or have any excretion by the renal tubules. And also, it should not have any extrarenal elimination. So that really meets the properties of an ideal marker for GFR. So in terms of measuring GFR, we can actually use some of the exogenous filtration markers. While the gold standard test being inulin, there is other available renal function markers, exogenous filtration markers that we could use, which includes chromium 51, ethylene diamine tetraacetic acid. In short, it's EDTA. There is technetium 99 labeled diethylene triamine pentaacetic acid, which is in short DTPA, which is being used for nuclear GFR measurements. And there is iohexol, but the gold standard is inulin because it has all these properties that we talked about as an ideal marker of GFR. But what's being used most commonly, or what's more practical, is a 24-hour creatinine clearance for measuring GFR, only because it's more convenient, it's less expensive, and patients can do it at home. While some of these other exogenous filtration markers that I mentioned about, it's more of a cumbersome test, and it's also not widely available in all the hospitals. But in clinical practice or in clinical medicine, we do not always measure GFR, except in certain situations like in evaluation of living donors. So what we commonly use for dosing medications or diagnosing CKD or for staging CKD, we use prediction equations or estimating GFR. And the most common marker that is being used currently is creatinine. We can go to the next slide. So what is creatinine? Creatinine is most commonly used endogenous marker for assessing glomerular function. It's a byproduct of muscle metabolism. It's freely filtered at the glomerulus, but there is about a very small percentage of creatinine that gets secreted at the the distal tubules. So in terms of looking at 24-hour creatinine clearance, there is usually about 10% overestimation of renal function when we use a 24-hour creatinine clearance. The main advantage of using creatinine is because it's readily available and also it's an inexpensive test. But we all realize that it's not probably the best marker in terms of assessing the renal function because of the fact that it can be influenced by a lot of other factors that can influence the levels of creatinine. For example, age or gender, the diet, level of protein intake, level of physical activity, or the functional status of the patient. All of these can affect the levels of creatinine or the production of creatinine. And also there have been studies that actually showed in AKI, when there is mild reduction in GFR, when the GFR is between 40 to 70, there is usually a lag time when the raise in creatinine does not happen. They called it a creatinine blind area. Now we'll talk about Cystatin C. So what is Cystatin C? It's a 13 kilodalton low molecular weight protein that's produced at a constant rate by all the nucleated cells. The low molecular weight and the negative charge of this protein makes it freely filterable at the level of glomerulus. And it's metabolized in the proximal tubules. Almost more than 99% of Cystatin C undergoes lysosomal degradation in the proximal tubules. So it's excreted exclusively via glomerular filtration with negligible amount of proximal tubular uptake. So before we start reviewing the literature on use of Cystatin C in our patient population, it's important for clinicians to know the differences between these markers in terms of interpreting the results using these markers for renal function. So we talked about some of the factors that can affect the creatinine levels, the age, the gender, the muscle mass, or the functional status of the patients, etc. When we look at the markers that affect the Cystatin C, it's completely different. Although both of these markers are to some extent influenced by these non-GFR factors, creatinine tends to be more affected or more influenced by these non-GFR factors. And many of these factors we commonly encounter in our patients, older patients or patients with poor muscle mass. We see our liver patients with frailty or low protein and low muscle mass all the time. And when we talk about the factors that can affect Cystatin C, they're completely different. And studies have shown with the use of steroids, there has been increase in levels of Cystatin C, and also with adiposity or fat mass. it has been shown that the cystatin C levels can be increased. Same with inflammation, the levels can be increased. In thyroid disorders and hypothyroidism, the cystatin C levels can be decreased, and in hyperthyroidism, the cystatin C levels can be increased. So one should be aware of all these non-GFR factors that can influence these markers when we interpret the results using these markers. You can go to the next slide. So what is the guidelines recommendations on use of cystatin C or creatinine for measuring renal function? So in 2012, the KDIGO guidelines actually recommended cystatin C testing when the eGFR is unreliable. Like when there are non-GFR factors that we just discussed that exist in a patient, they recommend using cystatin C for assessment of renal function. Also in patients, when the GFR is between 45 to 60, when they don't have any other markers of kidney damage, like in the absence of albuminuria, the KDIGO recommends using cystatin C for diagnosing CKD. And in 2019, the society actually further expanded the recommendation and concluded saying for diagnosis, for the initial CKD diagnosis and staging, they recommend using both creatinine and cystatin C. And listed here are the current CKD epi equation that uses creatinine and cystatin C. We can go to the next slide. So before we talk about the literature on use of cystatin C in the kidney transplant population or in living donors, we need to know what the data is on its role in CKD population. And there is a lot of literature on looking at performance of cystatin C as a marker of GFR in the CKD patients. There is also papers looking at whether it's associated with the long-term outcomes like cardiovascular mortality or morbidity. And from many of these literature, now we know that cystatin C can be a more accurate test in some patients, and it can also help with early detection of CKD. And studies have also shown that in diabetic patients, it can actually identify kidney disease much earlier than creatinine. The studies have shown that it can help with improving risk stratification. It can serve as a better marker to predict the cardiovascular risk, morbidity, and mortality. And it can help guide medication dose adjustments that Dr. Erin would be talking about. And it can also help with addressing some of the healthcare disparities. For example, when a patient gets identified with CKD earlier, they can be referred to transplant much earlier, and they can be waitlisted much earlier. So now we'll look at the literature on the role of cystatin C in kidney transplant patients. So there are some studies that looked at how cystatin C performs as a marker for measuring GFR, and there are some studies that focused on cystatin C as a marker for long-term outcomes, like cardiovascular outcomes. I'll be talking about some of the studies that looked at its performance as a marker of GFR in transplantation. So when we look at some of the earlier studies before 2012, most of the studies have actually shown discrepant results regarding use of cystatin C in transplant patients. This was a systemic review that looked at 10 studies, and they found that these studies had discrepant results in terms of performance of these equations using cystatin C and creatinine. But most of these studies did show that cystatin C-based equations more closely approximated with the measured GFR equations, measured GFR calculations. But the main limitation from these studies was that these studies were done prior to the CKD epi era. Currently we use the CKD epi equation for estimating GFR, but all these studies use different equations, the MDRD equations or the equations before that. And also it was, the another biggest limitation of the study was back then there was no standardized technique for measuring cystatin C. The reagents that were used for cystatin C were not standardized, and the calibration techniques were also not standardized. So that may be the reason why they saw discrepant results in some of these earlier studies. And then this study in 2016 by authors Kedis et al. This was actually published on CJSON in 2016. They looked at the performance of Cystatin C as a marker for GFR, and they compared it to CKD-AP equations with creatinine and also the MDRD equations against the measured GFR with iothalmate clearance. So they looked at the performance of each of these equations against the measured GFR calculation, and they looked at the accuracy of these equations, they looked at the precision of these equations, they calculated the bias with each of these equations. And what they found was, when we look at this graph on the left side, sorry if it's too small to read, but this graph is actually the eGFR Cystatin C equation. And what they noticed was the eGFR Cystatin C equation had the largest bias, and the eGFR creatinine equation had the least bias. And the combination equation, the eGFR with Cystatin C and creatinine, fell somewhere in between these two. And when they looked at the accuracy of each of these equations against mGFR using iothalmate clearance, they basically defined accuracy as percentage deviation from the mGFR. It has to be within 30%. And when they looked at that, those y-axis is the measured GFR, and the x-axis is the eGFR with different CKD-AP equations and MDRD equation. So this green line and the gray line, the green line is the Cystatin C eGFR, and the gray one is the combination equation. So that had those two had better correlation with the mGFR than eGFR creatinine or the MDRD equation. So they concluded from this study that in terms of looking into bias, although the Cystatin C equation had more bias, the combination equation with both creatinine and Cystatin C had the highest accuracy and less bias. So now we talked about how it performs as a measure for GFR, and this is a study looking at how it performs as a risk factor for long-term outcome. So this was a study that looked at the patient population from the favorite trial, and they looked at the performance of each of these equations with eGFR cystatin, eGFR with the beta-2 microglobulin, and eGFR with creatinine. And when there was decrease in GFR with each of these equations, there was increased risk for cardiovascular events with all of these equations. And then they tried to do more analysis by adjusting some of the baseline characteristics of these patients and also some of the transplant characteristics of these patients. And after adjusting for those factors, what they found was that decrease in eGFR with Cystatin C equation was associated with increased cardiovascular outcome. It actually served as an independent predictor for long-term outcomes, whereas reduction in GFR with creatinine alone did not have that association. So apart from serving as a marker for GFR and in predicting long-term outcomes, they also, there's also literature on whether it has any other role in transplant patients. And some of the papers looked at how it performs as a marker in predicting delayed graft function. And this was a paper that was published in 2015 by authors Fonseca et al. And they looked at a triple biomarker approach for predicting delayed graft function in kidney transplant patients. They measured creatinine, Cystatin C, and another protein called malondialdehyde, which is basically a lipid peroxidation end product. They looked at the combination of these products. They measured these products 8 to 12 hours after kidney transplant surgery. And they found that combination of these markers, as opposed to a single marker like just a serum creatinine, had a better capability of predicting delayed graft function. We can move on to the next slide. Now, we talked about role of cystatin C in kidney transplant patients. Now, I'm going to be focusing on its role in kidney donors. Now, we all know that, assessment of kidney function in donors is very crucial, and we really want to get the best test that's more accurate for evaluating the kidney function in our donors. But cystatin C in kidney donors is not widely studied. There is very few literature looking at performance of cystatin C in kidney donors. I'm going to be talking about some of the studies here. But when we look at the guidelines for renal function assessment in kidney donors, KDIGO suggests that we use eGFR from serum creatinine for the initial assessment, and we follow it with one another confirmatory test, and that test can either be a measured GFR using a race neutral formula, or it can be a 24-hour creatinine clearance, or it can be eGFR from combination of serum creatinine and cystatin C. That's what we're going to be talking about now, and repeating eGFR is the least preferred method. So this was a study that was published recently. They looked at performance of cystatin C in donors in terms of predicting pre and post-donation GFR. So they looked at the GFR calculation with all different CKD epi equations. Again, if this is too small to read. They looked at the capability of each of these equations in terms of differentiating a GFR more than or less than 90, more or less than 60, which is the bottom plot. And what they found was the combination equation, the 2021 CKD epi equation with creatinine and cystatin C had a better capability of differentiating GFR above and below 90 in correlation with the measured GFR by iothalmate clearance. And also it had the least bias. And the same thing they found with GFR above and below 60. So this was a Japanese study that looked at a similar outcome, the performance of CKD epi equation in terms of correlation to measured GFR using iothalmate clearance as the standard. So they looked at the different CKD epi equation, the CKD epi 2012 with cystatin alone, and 2021 with creatinine alone, and the 2021 equation with creatinine and cystatin C. They also compared it with the Japanese eGFR equations using creatinine and cystatin C. So they actually created a simulation model by using all these different eGFR equation, compared it with the measured GFR, and they simulated a model and looked at how many patients would have become more or less eligible by using each of these equations. They also looked at with each of these equations how many patients had overestimation of GFR comparing to measured GFR, and how many patients had underestimation of GFR. So in this Japanese cohort, what they found was the CKD epi equation tends to overestimate the GFR in this Asian population. But the risk for underestimating GFR was very less with the CKD epi equation. So again, although in the study that was based out on United States, the CKD epi, the combination equation was performing better, in this Asian cohort, it tends to overestimate the GFR. Now, this was a study by my colleague, Dr. Liaquette, and Dr. Poggio from Cleveland Clinic. They looked at pretty much the same exact thing, the performance of different CKD epi equation, and compared it with a measure GFR. And they looked at the accuracy, the precision, and the bias with each of these equations. They looked at 286 living donors in United States from 2015 to 2021, and they found that the 2021 CKD epi equation with creatinine and cystatin C had a better overall performance in terms of bias and accuracy. And this was actually more pronounced in African American donors. So knowing all this, it's also important to know what the limitations or the barriers of using Cystatin C. For quite some time, from the earlier studies, there has been concerns about the accuracy of the Cystatin C test. And the accuracy has actually much more improved over time. This was a 2019 study by the College of American Pathologists program. They looked at the accuracy of the Cystatin C test in United States, and they found that definitely the accuracy has much more improved over, in the last few years. And the other biggest limitation is availability of these tests. Yes, we want to do the test, but is it really available in all the US laboratories? They found that only 7% of the US labs have offered the Cystatin C test. And many of these labs also send it out to the external commercial labs for these tests. And also we have to consider the cost of the test. Although it's not a very expensive test, the Cystatin C reagents cost about $5 to $10 more than for what it is for creatinine. And the other biggest limitations with the Cystatin C is that not many people are familiar with what it is. Especially the other fields of medicine, not many clinicians are familiar with what it is, what the differences are between creatinine and Cystatin C. And also there is a lack of institutional policies or guidances towards using Cystatin C. Now, I will conclude with my last slide on some take-home points. So Cystatin C can be an alternative biomarker for estimating eGFR. And, one of the things that I get asked a lot of times is, what do we do with discordant results? When we get completely different results, eGFR results from eGFR creatinine and eGFR cystatin, what do we do with those results? So it's really important to pay attention to, the patient and look at if there are any non-GFR factors that we talked about, whether it would apply in a particular patient that makes it very discordant. But I would say it still remains a complex decision, and we really have to individualize, especially in the inpatient setting. And the combination equation, the CKD-EP equation with creatinine and Cystatin C tends to be more accurate. That's what we see from most of these studies, but also we need to keep in mind that this equation was developed in a relatively healthy population with a mean age group of 47 and with a mean measured GFR of 68. And combining markers can certainly help us with enhanced monitoring. And in kidney transplant patients, there have been inconsistent results. And in living kidney donors, the data is very limited. And also there's no long-term outcome studies using Cystatin C in donors. And there is definitely potential for more research using the new CKD-EP equation without race, and also combining with other novel biomarkers in terms of risk stratification, diagnostic accuracy, and therapeutic monitoring. That concludes my presentation. I'm going to hand over to Dr. Asrani.
Thank you so much, Dr. Balaraman. And then I'll just sort of build on some of the concepts that were discussed, but applying it to patients with cirrhosis. So in cirrhosis, there's data, but it's more limited as compared to kidney patients. But here's sort of a top-level summary of how do we see Cystatin C in patients with liver disease. So we know that it's associated with acute kidney injury, and it probably captures functional rather than structural change. It often gets elevated from serum creatinine by about 48 hours or so. So it can identify development of acute kidney injury earlier. Third, levels may be affected by active inflammation and by use of steroids. Fourth, it does not necessarily differentiate between causes of acute kidney injury, which is very common in patients with liver disease. Next, when the cystatin C rises, this may help us identify patients who are early stage hepatorenal syndrome, but in future stages, the cystatin C rise and the trajectory is the same as serum creatinine. Predicting future events like need for renal replacement therapy or SLKT is similar to serum creatinine. And elevated cystatin C levels do predict short and long-term mortality. So earlier capturing of acute kidney injury, representing functional changes affected by other things, and its impact is mainly earlier, but later on, its relevance as prognosis is the same as serum creatinine. Next slide, please. And the part of the issue becomes is, when the previous speaker talked about the role of cystatin C, we're talking about CKD, we're talking about more of an outpatient assessment. But when you talk about acute kidney injury and cirrhosis, the issue is that there are many things that can cause progression of kidney dysfunction in patients with cirrhosis. So here's an example of what can cause AKI in patients with decompensated cirrhosis. So starting from the top, there are factors related to the kidney, right? So if a patient already has acute kidney disease or CKD or normal kidney disease, that impacts what happens. On top of that, you add cirrhosis and its portal hypertension complications. An example going from left to right is the role of bacterial translocation, the role of arterial vasodilation, in the last part, the role of bile acids. And so a combination of both cirrhosis-related factors, kidney health-related factors, end up with sort of acute kidney injury. And again, acute kidney injury in cirrhosis patients can lie on a spectrum from functional to functional plus structural changes. So it really becomes hard to say when you're going to use one marker, such as cystatin or creatinine, which aspect of kidney dysfunction are we talking about in cirrhosis? And hence it becomes more complicated rather than saying it is a marker of chronic kidney disease. Next slide, please. And in patients with cirrhosis, when we use equations using cystatin eGFR, these often underestimate kidney function. So I want to guide your eyes towards sort of the bottom line results. So you have this dotted line that says 0. Anything less suggests underestimation. Anything over it suggests overestimation. So here we've just summarized several studies looking at cystatin-based estimation of GFR. And overall, using cystatin tends to underestimate GFR, and in contrast, creatinine-based overestimate GFR. Next line. And even as a biomarker in patients with liver disease, cystatin C has had inconsistent performance. So I'm going through different scenarios, for example, in patients with AKI or AKD or CKD or hepatorenal syndrome, or predicting hemodialysis or need for liver kidney transplantation or mortality. And if you guide your eyes to the column that says AUC, what you can see is that the range of prediction varies all the way from a flip of a coin to 0.98. So really good to maybe just 50-50. So the performance also of cystatin C as a biomarker in various studies may be inconsistent. Next slide. Here's a study that we just completed from our group to say, okay, what does cystatin C look like in cirrhosis patient as compared to measured GFR? So here we had about 250 patients who were liver transplant candidates, got a measured GFR, got cystatin C and creatinine measured at the same time. And what we saw in the bottom, in the right panel, is that if you look at quartiles of cystatin C, that predicted outcomes better than creatinine. So far what we're saying is that cystatin C may be slightly better than creatinine in predicting future outcomes. Next slide. And this has also been used in mathematical modeling. So if you have something called the MELD score, which we use in a liver patients to identify patients who are going to do well or not do well, if instead of creatinine, if you add MELD cystatin, which you see in the red line, that does help predict future outcomes better as compared to MELD score alone, maybe slightly. So there is some role in prognosis. So overall, from a prognosis standpoint, in the last 2-3 slides that I've shown, is that cystatin itself has some role in prognosis in patients with liver disease. Next slide. The question, however, becomes is practical application. If we have discordant results, then what do we do? So I'll walk you through this study. You see 3 different colors, which is the green, which is low, intermediate, and then high, which is red. So this is how different is cystatin C versus serum creatinine. And what you can see in this study, about a third of patients had a significant discordant result between creatinine and cystatin. If you can use that piece of information, what you can see on the right side is that the patients who had the highest discordant had the lowest survival. So once again, hinting at prognosis is that if there's a big discordance between creatinine and cystatin, then that can predict who's not going to do well in the future. However, what are the characteristics of patients who don't do well and have this high discordance? And that you can see in the small table at the bottom is patients who have complications of liver disease, such as ascites, hepatic encephalopathy, who are frail, who are sicker, who are female, tend to have high discordance, and therefore they don't do well. So yes, we can predict prognosis, but the problem becomes is practical application. Is if I'm going to use this at a bedside, how can I use this for clinical decision making? And cystatin C use in this scenario in patients with cirrhosis becomes a bit nebulous. If you can go to the next slide, please. We started based on some of our cystatin data, said, okay, let's just check and see, how often do we see discordant results? And in the last 3 months, actually, we checked in about 60 patients, and the median serum creatinine was 1. Median cystatin C in the same patient was 1.6. And what you can see on the right side is if we just calculated eGFR by creatinine, it was 76. By cystatin, it was 39. And by creatinine cystatin, it was 55. And overall, highlighted in the middle, the difference in eGFR by these different measurements was 33 mLs. And this actually caused a lot of confusion in our selection conference is now which one do we believe? Do we believe the cystatin, that the patient may be needing a simultaneous liver kidney transplant? Do we believe the creatinine, that this patient's okay and can move forward? Because historically, if I saw creatinine of 1, I would say this patient needs a liver transplant alone. And then patients have access to these results, and that adds another layer of confusion. So instead of providing clarity in our clinical experience on a day-to-day use of cystatin C has added some confusion. Next slide. So to sort of summarize that, yes, cystatin C in patients with cirrhosis in 2024 does have some role, right? It can identify early kidney dysfunction that's not captured by, let's say, creatinine. It does predict relevant outcomes, but performance compared to other markers may be similar or maybe slightly better. However, what we've noticed in our experience that real-time clinical decision-making based on cystatin C is still unclear given some of its limitations, and especially when we're talking about clinical implications such as organ allocation and need for kidney after liver transplantation. And I'll stop there and ask Dr. Barreto to take on the conversation.
Thank you so much. I'm pleased to shift gears a little bit and focus directly on the medication component. You can go to the next slide. Next slide. My colleague, Dr. Lemke, and I will talk about just general medication dosing principles with cystatin C, and then we'll try and go at what I think some of the chat conversation has been today, which is about practical application of this to transplant cases. Next slide. So as we think about medication elimination via the kidney, it's the net effect of filtration and secretion primarily. There isn't a lot of reabsorption of drug from the filtrate into the systemic circulation. And in general, we primarily focus on filtration because that's the easiest thing we can measure or estimate, as was mentioned by the previous speakers. And we use the proxy of serum creatinine-based estimated GFR or estimated creatinine clearance. You can advance. So you can see here, if you look at this dosing table, this is just a simulated dosing table from our institution looking at cefepime dosing. And as you can see across the top, there's categorical thresholds of estimated
GFR based on creatinine or estimated creatinine clearance, whichever you choose to use, as long as you still use creatinine, it's roughly the same. And you can see that we march out doses accordingly. But Cystatin C is kind of a different beast here. So you can move to the next slide. When we think about Cystatin C, it wasn't too long ago that I would give talks like this and people would say there's no evidence for Cystatin C for medication dosing, but that's just simply not the case. In a systematic review we published several years ago now, we demonstrated at that time, which predates a lot of some of this most recent conversation, that there's evidence from more than 3,500 patients or so looking at 16 different medications for the performance of Cystatin C for the prediction of drug clearance. Next slide. And you can see that in general, the key message is that estimated GFR from Cystatin C predicts drug clearance at least as well, if not better, than serum creatinine in most of these pharmacokinetic studies. But in rare circumstances, bearing in mind that these data are before or at 2017, the biomarkers were not typically combined, which has been shown to be some of the more accurate and precise estimates of GFR. Next slide. Now, when we think about drug dosing, as many of our attendees have already highlighted in some of their questions in the chat, there's a lot of challenges with discordance, and this comes up a lot in the transplant population. This is a data set of almost 18,000 patients with concurrent biomarkers with creatinine and Cystatin C during a hospitalization. And this is not specifically transplant patients, but it gives you a sense of the challenge that we encounter when we deal with patients who get a Cystatin C checked. And you can see, looking at the graphic on the right, that the mean discordance between estimated GFR and creatinine and estimated GFR and Cystatin C is 15 mils per minute. And when we think about medication dosing, that could be substantial. And indeed, as you move up the spectrum of GFR, oh, you can go back one first. As you move up the spectrum of GFR, the degree of discordance tends to go up. And you tend to see patients who have these 30 and 40 and 50 mil per minute discordant GFRs, which can be a real big issue when it comes to making medication choice. Now you can advance. And this introduces a particular challenge when we think about electronic health records that are used to guide clinical decision support for medication dosing. Indeed, if you look at just a specific patient example that we have in our electronic health record, you can see a variety of different eGFRs or estimated creatinine clearances that can be presented to the clinician that use different equations, different units of measure, and different biomarkers, all of which a clinician then has to make a decision about whether we're going to choose 13, 32, or 60 in this particular circumstance, or none of these at all to make their medication dose correct. Next slide. This is a particular consequence because if you look, for example, at this, there's inconsistent interpretation when you look across providers. So this is just one example patient that we presented to clinicians in a qualitative study. So this is a very standard example, 74-year-old gentleman, 99 kilos, serum creatinine of 0.7 and a Cystatin C of 2. And if you march out the GFR, there's significant discordance here between these two markers, as the normal value for both of them is around 1. And so one of the clinicians, this is an intensivist, said, we don't fixate on one item ever. We just look at a combination of different things. Whereas another internal medicine physician said, I just take the lower, whatever one it is, I just take the lower one because I'm a conservative person. So when it comes to medication dosing, then you can advance. For the first case, this could be a range of choices depending on how they interpret that set of data. Anything from 0.5 to up to 3 times a day potentially. Whereas in the last one, perhaps it would just be cefepime 1 gram every 24 hours. So this is 6 or higher fold differences in doses that are selected across clinicians simply by making additional data available to them. Next slide. That said, it's not all disappointing news. These are some data where we protocolized the use of Cystatin C in combination with creatinine as part of a vancomycin dosing protocol. And you can see, compared to historical control, that there was a statistically significant improvement in target vancomycin level attainment. And perhaps most notably, if you look at the box plot on the right in the top intervention group, this is the eGFR creatinine Cystatin C vancomycin dosing nomogram, you can see that there's far less spread in the data, meaning that it's a lot more consistent as opposed to kind of the potpourri that you see in the standard estimated creatinine clearance-based dosing. So there is opportunity that exists, but it needs to be done for medication dosing with intention. With that, I'm going to turn it over to my colleague, Dr. Lemke, to move specifically into a couple of cases to highlight how this could be done in transplant well.
Awesome. Thanks, Dr. Barreto. So like she said, we're going to hop right into some patient cases to apply knowledge gained today. In this first case, I want to offer you a 68-year-old female with interstitial lung disease who presented for bilateral lung transplant. She had a few comorbidities, including high sensitization, type 2 diabetes, hypertension, and currently she was transplanted, supported in the ICU, and we're treating pneumonia on top of it. Some other considerations for you: her weight is 50 kilograms, she's 155 centimeters, and her pre-transplant iothalamate clearance was 63 mils per minute. I've outlined her immunosuppression on the right-hand side and infectious disease serologies for completeness sake. And our mission today is to dose her cefepime, ganciclovir, sulfamethoxyl trimethoprim, and vancomycin. And we can proceed to the next slide. So on the right-hand side here, I've outlined some of our data points to help guide our kidney function assessment. It's post-operative day 2, so we fast-forwarded a little bit. Her serum creatinine is 0.54 and cystatin C is 0.86. Urine output has fell, which caused us to trigger the cystatin C gathering to get an extra data point. And when we plug all of those numbers into our various estimation equations, you can see variety there with 73 to about 85 in the different estimation equations, which from a pharmacist's perspective is somewhat comforting because we have a good ballpark of where we're dosing medications. But right here, I just want to pause and outline some of the considerations we need to think about with serum creatinine and cystatin C in this specific case. First of all, our patient has low muscle mass, and we know that she came into transplant with poor nutrition, which means that when we're looking at serum creatinine estimation equations, we might overestimate our actual GFR. Whereas in cystatin C, that might increase some of our accuracy. However, confounding this picture, she's just recently transplanted. We have a boatload of inflammation on board. We have huge doses of steroids, both of which may cause underestimations of measured eGFR when looking at cystatin C alone. But for initial dosing and carrying on our post-op day 2, we'll look at eGFR 73 to 85 and commit to something around 80 mils per minute. And I've included dosing recommendations for all of our antimicrobials on the bottom of the right-hand side. We can move to the next slide. So fast forwarding on post-op day 4, our serum creatinine is bumped up a little bit, but not super. It's now 0.63, but we see a rise in our cystatin C and BUN. Our urine output hasn't changed that much, but we're still worried about kidney function. When we plug all of our data points into our estimation equations, you can see a range here between 48 and 82 for eGFRs, which leads to quite a bit of confusion and quite the pickle when we're trying to figure out how to dose some of these antibiotics where the cutoffs fall in between those numbers. On the top right-hand side, I've included cefepime, ganciclovir, Bactrim, and vancomycin's different dose adjustments. And I've highlighted if we use our highest eGFR equation and what those doses would be in green, and then in pink, if we used our lowest eGFRs, what our dosing increments would be. And you can see we have some decisions to make. Now, all of the limitations for both cystatin C and serum creatinine that we outlined on the prior slide still play a role here. What I'll say that weighs on me a little bit as well is we can see a trend up in our cystatin C and BUN, and we know that the serum creatinine lags behind a bit in the setting of AKI, for which this patient is at high risk. With all of that said, we decided to commit to an eGFR of 60 mils per minute for dosing our medications and adjusted our ganciclovir and vancomycin accordingly. Now, knowing that we have this rise in cystatin C, we also decided, since we have availability, to get some vancomycin levels to help guide more precise dosing of that medication that could cause kidney dysfunction. Next slide, please. Now on day 7, we can see that the serum creatinine is starting to catch up here. It's now at 0.86, and our cystatin C is continuing to rise. Urine output is up, but that's in the setting of active diuresis. And now when we're looking at our different estimation equations, we have to choose between somewhere in between 28 and 62, which once again puts us in an uncomfortable place, particularly when we're worried about underdosing could lead to insufficient infections treatment and subsequent complications. But overdosing in this very vulnerable patient could lead to some pretty serious medication toxicities. We apply the same limitations, but this time looking at both the trend of the serum creatinine and the cystatin C, we've reduced our estimated eGFR for medication dosing to 40 mils per minute, and the outline recommendations are in the bottom right. Next slide, please. Now, I wanted to just directly address my approach that I was hoping to outline in the last patient case. When I'm thinking about incorporating all of this data, I start with who would benefit from a cystatin C. Typically, the big flags that I see are acute illness, extremes of muscle mass, so both those patients that are less than 50 kilograms or greater than 100 kilograms, certainly, poor nutrition as well. And then what I do is I plug in all of those data points into my different calculators, and I use the National Kidney Foundation calculator because it's just easier to get them all at once, and look at what my range is. Then I consider the strengths and limitations of both the serum creatinine and the cystatin C as biomarkers in this specific patient in this specific time, and start to weigh which way I'm leaning in terms of what would be the best way to estimate their kidney function. This next step is the most important, and that's to commit to a ballpark of eGFR for your patient. Declare, I'm estimating an eGFR of 40 to 50 mils per minute to guide my dosing, and I'm going to share this on rounds and with my providers and build consensus, add their opinions to adjust our approach. Then we're looking at each medication's kidney function dose adjustments and asking ourselves for each of those medications, what's the kinetic profile look like? And are there properties that would affect efficacy or toxicity for the patient in front of me? What are the risks of dosing too high and too low in this person? And lastly, we need to commit to a dose and form a follow-up plan to reassess kidney function. And I can't highlight the importance of that enough. What data points do I need in order to change my recommendation? And how quick do I need to monitor this? Next slide, please. Now, I'm going to speed through this next patient case. Essentially, it's a 50-year-old kidney transplant recipient who shows up to my clinic for the treatment of cytomegalovirus viremia. Importantly, she has obesity. She has a history of coronary artery disease and hypothyroidism and type 2 diabetes. And she's a CMV mismatch with numerous rounds of thymoglobulin for induction and then rejection. And our task is to dose valganciclovir as we're switching from prophylactic dosing to treatment dosing of cytomegalovirus. Next slide. Now, on this slide, I'm going to break down some of the data points here and just skip to the main points. We have time for some Q&A. Essentially, what happened is when she was first prescribed, or at some clinic appointment 2 months ago, she was prescribed valganciclovir. The serum creatinine was rose, so a cystatin C was gathered. They estimated that the kidney function was between the 40 to 60 range and dosed her valganciclovir prophylactically at 450 milligrams daily, which seemed appropriate at the time, and from my estimation, seemed appropriate as well. A month later, only the serum creatinine was gone, but chart notes indicated we were dosing valganciclovir based off of cystatin C, and it continued at that 450 milligram dose, even though our creatinine clearance bumped up to 80, and we should have probably increased to 900. Today she comes in, you can see the serum creatinine and cystatin C are 1.1 and 1.4, and we have consistent eGFRs greater than 60, which likely indicates my suspicion that we were underdosed. And now we have the situation where our cytomegalovirus viral load is 15,000. In this patient, I wanted to highlight the reassessment piece, not setting and forgetting those doses when we're using alternative markers for kidney function is so important. And then also to highlight obesity, steroid use for this patient, the hypothyroidism and cardiovascular disease all modify the reliability of cystatin C in her, and maybe should have leaned us more towards blowing up on our estimated glomerular filtration rate for dosing medications at that time. So my recommendation was to skip to treatment dosing, and I was dosing off of a creatinine clearance of greater than 70 for either IV ganciclovir depending on symptoms or valganciclovir for CMV treatment. The next slide is some takeaway points for our case. Big things I want to take away is the statin C is an excellent marker for drug clearance. It's a good thing to trend after solid organ transplant. Is a very useful tool for figuring out which way we can lean, because there are certain situations where you're paralyzed by the complexity of the person in front of you. You know there's high toxicities from the medications, but you also know there's serious situations, particularly when we're treating infections, where we don't want to underdose and risk our patient not effectively overcoming the infection. When we're using these equations, build consensus and acknowledge the uncertainty, and always make a plan for reassessment, particularly when you see those discordant cases and we're making large dose adjustments using that Cystatin C piece of data. And with that, I think we can move on to questions with our moderators. Thank you.
Thank you so much to all of our speakers. That was a wonderful conversation. We do have just a couple of minutes for questions here. A lot of our questions in the chat were really surrounding drug therapy, so I'm glad we got to catch the tail end of that with Dr. Barreto and Dr. Lemke. One that came up a couple of times was really in regards to interpretation in the setting of steroids, given that steroid utilization is so has so much variability across our transplant centers. So if any of the speakers want to take a commentary on the level of impact that steroids would have on the Cystatin C interpretation.
I can comment on that. So the studies that looked at correlation of steroid therapy with levels of Cystatin C, most of it were animal studies. They looked at the levels in rats and the other animal models, and they found that there was a correlation with steroid therapy and increased levels. But in the human studies, the results have been sort of inconsistent. There was actually a study that looked at Cystatin C levels in critically ill patients with steroid therapy when they're on stress dose steroids, and they found that it did not have any correlation with hydrocortisone or IV methylprednisolone, but it did have with prednisolone. So the results were really variable, but most of the studies did show some increased levels of Cystatin C with steroid therapy. And also they found that the effect of the steroid effect can wane over time. If the patient is on a chronic, dose of steroid, they shouldn't really have, it shouldn't really affect the Cystatin C levels.
Thank you, Dr. Balaraman. Another question that came up during this session was about, of course, clinical application and real world use. I noticed a number of you guys had attested to either running them for some of your patients, but there was commentary that this is potentially a send out test. So I'm curious across the board here, are these send out tests for the majority of your institutions, or what is the turnaround time and how does that factor into your decision making for use?
Yeah,
I'll take the inpatient setting, because I think that that's probably not where a lot of people are for their transplant candidacy conversations. For the inpatient setting, if you can't get turnaround time in less than 12 hours, I don't think that this has a place. There's too much dynamic physiology and decision-making that happens in acute care. So I think you need rapid in-house turnaround for Cystatin C testing to make it viable, consistent with how you would expect it to be for creatinine. We have in-house testing with a 3-hour turnaround time. And I think that a lot of places in the future, probably not yet, but in the next 10, 20 years, you're going to see this in-house because it can be run on standard platforms. Outpatient, it's a different level of urgency.
We have a question for Dr. Asrani. Just given your center's experience and recent publication that you highlighted using Cystatin C for components of predicting mortality, and then your beautiful commentary on how confusing that can be as part of your listing conversations, are you continuing to do this in all patients, or are you looking at select patients for use?
Yeah, so in liver patients, we actually just paused it because we thought it was causing more confusion than clarity. And we were going to review as a group to say, are there subsets that we should be using as Dr. Barreto highlighted? Sorry, and let me actually just make one more plug, is that there is a group called Harmony, which is hepatologists, nephrologists, about 40 to 60 individuals, about 30 institutions, who are going to prospectively look at Cystatin C collection across the US to answer some of these questions.
One last question before we end that I also am seeing in the Q&A portion is just in general, and anybody can answer this, since all of our drug labeling usually utilizes Krakow-Galt or MDRD, in what scenarios would you be flagged always to potentially check a Cystatin C in a patient versus when you would maybe just utilize our measures that we normally have quick access to with Krakow-Galt and MDRD?
For me, but working both in the hospital and clinic, there's people that present in front of you that that serum creatinine is just not correct. And it puts you in an odd place where if you follow the Krakow-Galt and the package insert exactly, and you don't make those dose adjustments, you see real toxicity. One of the drugs we see that for all the time is valganciclovir and ganciclovir. It just causes some real problems in our patients. I think that, yes, it makes you uncomfortable to use a Cystatin C, certainly. I did when I first incorporated it into my practice. But I think as a society and group, this would be a call to action to advocate for looking at studies that look at Cystatin C and successive drug dosing, using it more thoughtfully in your practice, and sharing your experiences so that we can more confidently use some of these markers that are extremely useful in dynamic situations to dose drugs to the specific needs of the person in front of us and avoid a lot of that toxicity, yet yielding the benefit of the drug that we're giving. Sorry if I cut anyone off that platform.
I appreciate what Adley said. I completely agree. I do think that in general, a few key messages. I think at the population level, use of the combination equation is often the most reasonable middle ground, because there are non-renal determinants of creatinine and non-renal determinants of Cystatin C, and oftentimes the mess can be mitigated by putting them together a little bit. However, at a per patient level, that's not realistic in certain circumstances. We've all seen those people who have undetectable creatinines due to muscular dystrophy or whatever it happens to be. And using the creatinine in those circumstances is just going to drag the GFR up. I also wanted to just put a note in about the specific questions about package inserts and what the package inserts say and whether we should or should not anchor to those as we're making decisions. It may be true that creatinine-based equations were used in pharmacokinetic calculations in phase 1 and phase 2 trials that are old and drove package insert decisions. However, the applied use of medications in complex patients was never a part of approval trials, right? Drugs get approved to get on the market and in easy to treat patients without end organ dysfunction and disrupted physiology. And the transplant population is not that. And so all of these decisions are going to be very nuanced. And I think a lot of the key principles that Adley and our other excellent speakers highlighted about making choices need to kind of really be individualized.
Thank you so much for those thoughtful questions. And with that, I want to thank everybody for joining us today. As a reminder, the recording of this webinar will be available on all ACCP hubs. We hope you have a great rest of your day, and any questions we did not get to, we will try to look through those and have speakers answer and see if we're able to send those out. Thank you again.
Great, and thank you all to all of our presenters, all of our attendees. This was a really great, engaging webinar. So just thank you to all the COPs and ACCP for making this happen. And as a reminder, we do have a evaluation survey. So please make sure to complete that so we can help keep our content engaging. And thank you all.